Hi, good afternoon, everyone. Thank you for joining for this week's Advanced Critical Care Ultrasound teaching. We're just going to spend about 20 minutes talking about LV size and function. And this is the starting off of the academic calendar, so we'll start off relatively slow. We'll go through a couple of cases, and over the course of the year, we'll get more and more advanced as we go, okay? So please interrupt me if you've got any questions. Otherwise, let's just crack on. So I think particularly with LV size and function, it's important that we know how to measure it accurately. We know how to communicate efficiently, because this is, if for no other reason, I think that when we're talking to cardiology colleagues, they're going to want to know that measurements that we're making are accurate. So that means they're reproducible, so that you can compare when someone's been in ICU to when they're on the ward, you can actually compare measurements, and also enable us to communicate efficiently, because things like ejection fraction can be really important from a cardiologist's point of view. It can help try and determine whether you're going to be sending someone for a valve replacement or not, if it meets up with symptoms, for example. And so we just got to make sure we're measuring it properly. We need to define these measures, I said, for things like to know how to do it for aortic root measurements if we're doing it versus M mode. And systolic function is obviously one of the main things that people want to do echoes for, particularly if a patient is hemodynamically unstable. And let's talk about some of the problems with each of these as we go along. This is the main guideline I think that I use. I think most people use. If you use anything else, please let me know. But I think this is the main one, right? It's written about 4 years ago by the American and the European associations of echo, and it's extremely robust. I spend most of my time just looking through the tables. I think the tables and little pearls they've got in highlighted sections are super useful, and they give us most of the information, and I've stolen a lot of the tables that you'll see in this talk from there. And I'll tell you what, I'll also put a copy of this guideline that's freely available up on our Dropbox link, which you should all have a link to. So let's just first talk about how we're going to measure these structures, because we got to remember that the heart's a pretty complex structure, right? It's got that three-dimensional structure and it twists. But we've got a two-dimensional imaging tool, and we're looking at this complex three-dimensional structure. So what we're really seeing when we're doing our echo is a picture that looks like this. This is a cartoon I've stolen off the guys from the Mayo Clinic, and thanks for them for letting me borrow this. So we're just looking at a 2D slice like that. So we're looking at sort of an area change almost, and we can look at it in different angles. So you've got our, say, two-chamber view here, and we've got our short axis view, and we can look at area changes. And if we wanted ejection fraction, obviously we're doing the 4 and the 2 chamber. But if I can persuade you that that area change that we're looking at, we can make some geometrical assumptions. It's actually a little different from reality with what's going on with this quite complex twisting motion. And there's some data to suggest that even up to 30, even 40% of the systolic function, or that vortex of blood that comes out of the left ventricle, can come from this twisting function that we don't really assess at all. So it's worth remembering that we talk about ejection fraction as this kind of be-all and end-all for systolic function, and as a matter of fact, it can be a little bit more complex. So I guess where this theory of HEF-PEF and HEF-REF comes up, with the idea that you've got heart failure with preserved ejection fraction, but you can still have symptoms of heart failure. And is that a diastolic dysfunction, or is it some kind of twisting dysfunction? And I guess that's where the research is starting to try and discuss, particularly with things like spectral tracking. So the key pearl, I guess, that we're going to talk about when we're doing our echoes is this idea, and this is the same for basic echoes, it is with advanced echo. If you've got an abnormality in one plane, you've got to back it up in another. And when you're looking at left ventricle function or regional wall motion abnormality, this counts the same. And that if you've got an abnormality in one view, like you think the ejection fraction is down in a parasternal long axis view, you've got to go and check it out in your apical 4, 2, and short axis. Okay. So we've kind of gone through this already about why quantification is important, and it's mainly so that we can be consistent amongst us. We're consistent when we're comparing studies and when we're communicating with each other, all right? I think it can impact clinical management, some of these things, a bit more with outpatient cardiology decisions, I think, more than critical care areas, but it certainly can impact clinical management with valvular assessment and diastolic function and things like that. So we'll start off by talking about LV size and volumes. So first of all, the LV size assessment. We're going to start off with our standard view and our parasternal long axis view. We can have a subjective assessment where we can use the little markers down the side of the the centimetre markers down the side of the screen. And I use a cutoff of about, say, 58 millimetres for blokes, or about maybe 6 centimetres, we say, for subjective assessment. And anything greater than 6 centimetres at end diastole is getting towards being dilated. And if it's somewhere close to that, I'll go ahead and do quantification. So we've got a subjective assessment, and then with quantification, we can use objective measures with M mode. So you stick down your cursor coming down through the tips of the mitral valve leaflets, and you've got to be perpendicular. So if you imagine a line straight down the gun barrel of that ventricle, you've got to be exactly at 90 degrees across it with your M mode to make an accurate measurement. And you can get a picture that looks like this, so that we can get an idea during systole, which is from the beginning of the QRS complex to the end of the T wave. We can have those walls coming together, and we are going to measure it at its maximum diameter just at end diastole. So this is maximum diameter. Sometimes that's not exactly in line with the QRS. So just remember that sometimes this is not absolutely perfect. And so you pick the greatest diameter possible. And maybe you could argue I could probably maybe have come in just a little bit to get that maximum diameter. And that's the diameter for the left ventricle internal diameter during diastole. And greater than 58 for guys is abnormal, 56 for girls. And then you can do it in end systole as well. And that's when it's at its closest portion, and that's typically at the end of the T wave. Okay, you're going to get the Tycholt's method that comes in there that gives you both a fractional shortening as well as an estimation of ejection fraction. Let's start off with, why don't we start here, Louise? So what's wrong with using, why have I said this lacks accuracy? What's wrong with our Tycholt's method for ejection fraction?
You mean the fractional shortening?
No, so the fractional shortening is just a percentage difference between the internal diameter in diastole and the internal diameter in systole.
Okay.
So that just says, yeah. So the Tycholt's is making, actually it's ejection fraction. Do you know how it's making that estimate?
Well, it's only making the estimate on one plane.
Exactly.
So that's
and not even just one plane,
radius.
it's on like two little points on that very complex structure. And it does it by using this idea that there's this kind of bullet shape to the ventricle. It's using a lot of equations I don't quite understand that I probably went through when I was 15. And it's basically it's estimating what the ejection fraction is based on 2 points, considering there's no regional wall motion abnormalities and that you've measured them perfectly, and then you're cubing the diameters. It's open to lots and lots and lots of errors. And so that's why I say it lacks accuracy. It's not something that I look at all, I'll be honest.
Well, haven't we gone onto the stage now where we should just ignore it? Why do we have to keep going about old methods that aren't acceptable?
I don't know. I completely agree. I don't think this is
the ones that we use.
Yeah, I agree. And I think probably, I think a subjective assessment would probably have as much accuracy as this, if not more, maybe. And please do chime in if you got anything more. Cool. So, as we mentioned, we've got to make sure that we've got our measurement correct. You can see in this cartoon here, if you're off axis, you're going to overestimate the size of that left ventricle. So you've got to make sure you're absolutely perpendicular across that left ventricle to make the measurement. And that's why in the guidelines, they're going further and further away from this and just saying, maybe just use 2D data and just scroll through, and you choose where that mitral valve just closes, and that's your end diastole. And then it squeezes down, and just before it opens up, that's end systole. And you just measure it on the 2D picture, and I'll show you an example of that if we have time. So here you go. Here are your diameters that we can use. So, so normal values for 2D echo parameters. So we've got males, and they normally use the upper value of the 2 standard deviation range, so 58, and then the UTS are 52 they're going to use for girls here. So 58 and 52 is the standard values that we'd use for saying in the ventricle starting to get dilated. So where are we up to next? Bijeth, do you want to kick off with this? I'll just unmute you. Bijeth, what do you think of this image? So let's say if I started making measurements as we talked, I tried to find my end diastolic dimension. What do you think about it?
It's going to be completely wrong because it's off axis and it's not perpendicular to the pericardium and the posterior wall.
Fantastic. So I completely agree. So I don't use this. I think it's useless. So I'm not going to use that to make measurements. But this picture is also off axis based on that rationale, right? So do we completely ignore this? Is there, so we got numbers here of 68. So you're saying we don't believe that, and I'll agree with that. But is the image completely useless? Is there any other information you can glean from it though?
Well, probably you can measure the wall thickness, and that could give us an idea.
Yeah, maybe that will still be a little bit inaccurate as well, because again, if you're not perpendicular, you're still going to overestimate the wall thickness. So I might just pick up on some of that terminology and say that you probably overestimate the wall thickness as well. But what about function?
Yeah, the amount of contraction the ventricular wall has could give us whether there's any regional wall motion abnormalities or not.
Nice. And do you think the regional wall motion abnormality, do you think there might be a regional wall motion abnormality? And what do you think the systolic function is going to be?
I'm not sure about the systolic function, whether we can assess it with this image, but definitely the chronicity depending on the wall thickness, and obviously the contraction based on, we can assess the regional wall motion abnormalities, I think.
So I think there are a couple of clues that we can pick up about systolic function on this. So I agree with most of what you said. But if I show you normal, so that's normal, right? Can you see how the walls go together during systole, approximately the same amount each time?
Yeah.
We can maybe suggest that on this image here, we don't have, what wall is the ventricle is this?
Anteroseptal.
Nice, so anteroseptal and?
It can be inferior or posterior as well.
Yeah, inferior lateral, yeah, nice. And we can see that the movement of this anteroseptal wall is less than of this infralateral wall. And that may suggest we've got some regional wall motion abnormality. And also you see it's not coming in as far, which again suggests that maybe the systolic function is not perfect, or we're just dealing with an area of regional wall motion abnormality. The last thing I'm going to talk about is what am I trying to get at here with my cursor bouncing around between those 2 points?
It's the E prime separation.
Beautiful. What's that?
Well, if it's more than, I think the number is 7 millimeters. If it's more than that, it can give us an idea about the systolic function being reduced.
Beautiful. I think it's more like a reduced cardiac output, I think it is. And maybe it's been linked to maybe an ejection fraction or something less than 40, or basically the valves not being opened up enough. It's a bit like that, I think I call it, the pseudo-severe aortic stenosis, where the valve doesn't get open because there's not enough blood coming through. Yeah. Pseudo-low flow aortic stenosis, something where if you actually make that ventricle work harder, the ventricle opens up more. It's just blood flow going through a ventricle and the valve leaflet's not opening up enough. Nice. Yeah. Well done, mate. So yeah, we can say, even though we're off axis, we'll say that the LV is probably not normal in size and it's got some poor function, regional wall motion abnormalities. Got to assess in other views. All right, left ventricle size. We know it's a complex shape which changes with disease. We've got to understand that when a ventricle starts changing, some of the shape of that ventricle will change, and that's going to change some of these assumptions that we make when we're looking at it in different directions. Okay, so the idea is you've got to use all your images available to start making assessments on how that ventricle is working. Okay. Right, who wants to take this one? How are we going? Ben, are you up for having a crack at this MCQ for us?
I can happily guess one of 4.
Fantastic, good man. Okay, so when you're comparing M mode to 2D echo, is the lateral resolution of M mode superior to 2D echo? Is the temporal resolution of 2D echo superior to M mode? Is the axial resolution of M mode equivalent to 2D echocardiography? Or is the axial resolution of the 2D echocardiography depth dependent? This brings out ultrasound physics, which I'm having a crack at this year.
Which is clearly, at the moment, not a strong point of mine.
Let's just remember, so when the sound wave's coming down from the echo probe, it's much better in the axial resolution trying to tell a difference rather than in the lateral. And that's because the lateral resolution is made up by lots and lots of ultrasounds that sort of funnel in. And that's why the focus position is so important, to get in the area that you want, because that will give you the best lateral resolution. But the lateral resolution is nowhere near as good as the axial. Okay. And if we take that as our first point, the second point is that M mode, you just have lots and lots of single ultrasound beams that make up a 2D picture. And all an M mode is just sticking down one of those lines. So the lateral resolution of M mode is not going to be superior to 2D because it's doing exactly the same thing. Excuse me. So the number one is wrong, because the lateral resolution of M modes is just looking down one echo site. The temporal resolution of 2D echocardiography is superior to M modes. That's wrong, because to make a 2D picture, one picture, we've got to take up about, it's anyway, it's been like 180 to 256, depending on the width of your ultrasound beam, of those lines to make up a 2D picture. So you have to have one big sweep, makes up one picture. M mode, it's just one line going backwards and forwards, so you can have much better temporal resolution with M mode than with 2D.
Yeah. And
the axial resolution of M mode is equivalent to 2D is the correct answer, because it's exactly the same physics.
Yeah.
Okay. And axial resolution is not depth dependent. It's all about the size of your frequency. So if you increase your frequency, you get better resolution, because you've got a shorter pulse of ultrasound, which can differentiate between two little dots better. So axial resolution is frequency dependent, not depth dependent.
Yep.
Okay. And that is lifted straight out of, I think, the physics module from the DDU website, example questions or something. Okay. So that's how they'll do it for the DDU part one.
Mm-hmm.
Cool. Nice. There we go. We just went through that. Right, let's talk about ejection fraction. So we've got to be measuring ejection fraction as accurately as possible. And to do that, we've got to make sure that we are not foreshortening any images. And that means that we've got to image right from the apex of the ventricle in the 4 and the 2 chamber. We then use the Simpson's biplane, where it separates up these, it separates up the area that you've drawn into 20 little elliptical circles, and then it adds up the volumes from there. So first of all, you've got to make sure you're not foreshortening the image. So you image not from the apex, you image somewhere else. And there are a few ways that you can figure that out. So first way is to make sure that in your 4 chamber and your 2 chamber, when you're measuring that longitudinal measurement, you've got to make sure that the 4 and the 2 chamber are within 5 millimeters of each other. If they're not, you're probably foreshortening the image, or you're measuring it wrong. Okay? So that's rule number 1, is you've got to compare that long axis from your 4 chamber to 2 chamber. Yeah. Second of all, when you're tracing it, you're trying to ignore the trabeculations, ignore papillary muscles, if we can see any of those in there. Maybe it's a bit of an amputee displacement, but maybe papillary muscles in there, you ignore all of those. So you're just looking at that endocardial border where you don't have any trabeculations or pat muscles. You can try and help yourself by reducing the sector width, reducing the depth, so you get the best temporal resolution, and you measure it just where the mitral valve closes, just as it closes, that's end diastole, and then as it contracts down, just before it opens up again, that's end systole. And you measure it up at end diastole and end systole, and you'll notice here that the aortic valve is closed in both, because it's just closed, it's just before it opens. All right. And then the last thing, a little tip and trick that I picked up off David Playford, the professor of cardiology over in Perth, and he came up with this one. The apex of the heart stays stationary, and it's the base of the heart that moves up towards it twisting. The apex twists a little bit, but it stays stationary. It's the base of the heart's that moving. So you know where the mitral valve and the atrioventricular valves are, they move towards the apex. So when you're looking at an echo image, the apex should stay still, and he describes it almost as getting a thumb and imagining that your thumb's on top of the apex, and the apex should stay on your thumb. It should thicken if there's no original wall motility, but it should stay fixed. The base comes towards it. If you see the apex moving up and down, that means the potential of foreshortening the image as well. So I thought that was a nice little tip and trick for that one. Okay, so I think it's really important. And maybe the last thing I'll say is I find it quite tricky sometimes to trace the inside of the endocardium and try and know exactly where it is. And one of the things that's really tricky is sometimes with the trackball not going off. When you're tracing these things out, if you can see I'm tracing it out and I'm looking at look at my cursor, if you can see it, that's how you can make errors. What I'm actually doing is I'm not looking at my cursor. What I'm looking at is about 3 centimeters further on. So my cursor goes where my eye follows. So it's like driving a car, right? So if you're driving a car, you don't look at the end of your bonnet when you're going around the corner. You look at the corner and the car follows you. So get your cursor to follow your eyes. So look ahead where you want your cursor to be, not at your cursor. So I don't know if you've got any other tips and tricks. It's just all right. So as well as ejection fraction from the Simpson's biplane, we can also get our volumes. Volumes are a bit rubbish compared to the reference standard of MRI, and they're always going to sort of underestimate it by about 5 to 10 mils. Obviously, we frequently get our apex foreshortened. I find the endocardial border sometimes really hard to see, particularly the lateral wall in the 4-chamber view and the anterior wall in the 2-chamber. And maybe that's because our patients are normally lying on their back or they've got COPD or something like that. So just make sure you try and get those as best you can. And then the last thing to say about, I guess, Simpson's biplane is you're looking at a complex structure in 2 different planes. Of course, you can have abnormalities in other areas that you're not assessing. So this is an example of one that's, I guess, that I'd probably find tricky trying to measure. And this is the kind of example where we might not say that echo is, the ejection fraction of the Simpson's biplane is brilliant. And in this regard, we'd probably be saying, maybe we've got to do things like use contrast, or we've got to just eyeball it. I'd probably be saying that this is, probably mildly impaired systolic function. Try and have a look at it in another view. I'd say that ejection fraction, I wouldn't trust if I did that. And probably the best is a subjective assessment. You've got contrast, absolutely you can do it. You can see a beautiful endocardial border definition. And what looks like up here is either we're probably dealing with some form of thrombus that's sitting up here. You see this big black mark up at the top here. And we are missing that when we're doing some of our dodgy imaging that we do in our critically ill, or we can't get good pictures. Often, if you can, I think you'll find a lot of thrombus if you go looking for it with contrast. I might skip through these just in the meaning of time. So left atrial volumes. So if you're doing left ventricle, we can also do left atrial volume. Similar theories apply. You measure it at end diastole, and you're avoiding the trabeculations, avoiding pulmonary veins, avoiding left atrial appendages, and you use the 4-chamber and the 2-chamber, and from that you can get your left atrial volumes that ideally you should index, but index to body surface area. I'm imagining that most people's units are as bad as mine at measuring body surface area, and we're pretty bad with height and weight measurements. And so if I have to try and index, I either just use an average of 1.9 body surface area for men and 1.6 for females. And that's, ideally you should be indexing those measurements. Okay, regional wall motion abnormalities. Lewis, the Anterolater Rule can be assessed in which view?
The 4-chamber.
Fair enough. Fantastic. So for those doing the DDU, that is going to be asked to you in your exam at some stage. And it will be asked probably in transesophageal as well as toe. It's just a nice way of getting people doing it. And as you said it, Lewis, is totally fine. I have to do exactly the same. I have to stop, I have to look in the air, and I have to think of this picture. And I start with my 2-chamber, because the 2-chamber I can remember with my anterior wall on the right side of the image and the inferiors on the left side of the wall. And then I have to work my way back. And I imagine myself in my apical view, taking my apical 2-chamber, and I got there because I rotated 60 degrees from my 4-chamber view. So from my 4-chamber view, I rotate anti-clockwise 60 degrees to get to my 2-chamber, and then I go another 60 degrees around to get to my long axis, and that's the same as my parasternal long axis, right? Or a 3-chamber view. And that means that if it was anterior and inferior for my 2-chamber, it's anterolateral and infraseptal for my 4-chamber, and it's anteroseptal and infralateral on my parasternal long axis or on my 3-chamber view. So every time we're looking at an image, just try and get those in your head, just so it comes off as clockwork. That's it. Regional wall motion abnormalities. This is at best a a guideline. I think we all know from looking at angios and all the rest of it that the coronary arteries can be in areas that are outside of this, but this is the general idea that if that's your left ventricle, the LAD sort of supplies the anterior section, the circumflex does the side, and the right coronary does underneath, and there's overlap between them. Our scoring system is normal, hypokinetic, akinetic, and dyskinetic. They took out aneurysmal in the last set of the guidelines. So normal is thickening greater than 50%. Hypokinetic is thickening but less than 50%. Akinetic is no thickening. Dyskinetic is movement away during systole. Okay, so moving in the wrong direction during systole. And last but not least, systolic function. We've said, as Louise was saying, Tycho's method is rubbish. We can look at our wall motion on our M mode, and we can look at our E point separation, and greater than 7 millimeters suggests a reduced cardiac output. So that's the movement of that anterior mitral valve towards the septum, and normally it should go right up against the septum, and if it's a long way away, it's reduced cardiac output. We've got our subjective assessments, and we've got a Simpson's biplane on 2D imaging. And a subjective assessment, you've got to use as many views as possible. For our Simpson's biplane, we've got to use our apical 4 and apical 2. Lee, you can't do it. Where about you? What do you think about our doing Simpsons on these bottom 2 images here, Anne-Marie?
They haven't got great endocardial definition.
Nice. They've got dodgy endocardial border definition.
They're not LV focused views.
They're not LV focused views. Very nice. Yeah, foreshortened.
A little bit.
The 2 definitely.
Nice.
4 less so.
Yeah, and again, I'm just going to imagine putting my cursor up at the top. I think we're seeing a little bit of movement of the apex coming down in, and definitely if I put my apex over here, you can see the apex moving down, and that would suggest that we're foreshortened as well. So probably I would be going with subjective more than Simpson's biplane if I was just going to use those pictures. Blah, blah, blah. I think you all know about ejection fraction, and there are cutoffs, mild, moderate, and severe. And severe less than 30, moderate less than 40, less than 50 for mild, and greater than 55 or whatever for normal. Tissue Doppler imaging, we'll talk about this maybe a little bit more with diastolic function. So tissue Doppler imaging is looking at that movement rather than sort of thickening or anything. So it's the movement of the annulus of the mitral valve. And particularly that's then the movement in a longitudinal direction. And the reason why that's good is just looking at longitudinal function, which is mainly done by the subendocardial fibers of the left ventricle, which are the ones that are most sensitive to ischemia because they're furthest away from the coronary arteries. So you've got coronary capillaries to get down to the subendocardial layers. And cutoffs about 7.5 of telling you whether you've got some form of reduced systolic function. And particularly I'm talking about the S prime. So I don't know how well this comes up, but that's the movement during systole. So systole beginning the QRS, the end of the T wave, it's that movement up. And again, we'll talk about that a little bit later maybe. Cool, we've also got Doppler. So Doppler, if you've got a central directed mitral regurgitation jet, it's got to be central. We can look at the change in pressure and how long it takes to do that. And the change in pressure we're looking at is particularly from 1 meter per second up to 3 meters a second. And then if we're using the modified Bernoulli equation, that means a difference of 32 millimeters of mercury. So we do 32 millimeters of mercury difference divided by the time it takes to do that. And we can look so it's the change in pressure over the change in time, millimeters of mercury per second, and we get cutoffs of normal is greater than 1200, abnormal is less than 800. You have to have a good Doppler trace, centrally directed mitral regurg area. It's going to be load dependent because you've got to have a nice profile that's in there, and you can use it if everything else isn't working well, but it's another tool in the arsenal. We've also got our stroke volume. We'll talk about this in hemodynamics maybe at another time. And a normal ejection fraction does not mean you've got a normal stroke volume. And an abnormal ejection fraction does not mean you've got an abnormal stroke volume. And that's why you've got to look at both and take it into the hemodynamic profile. All right. So good. So we'll go through one quick case. So let's just remember that we want to do measurements because it helps our communication. They should be a part of every routine full study, measuring, or at least subjectively assessing ejection fraction and LV size and function. Know your walls. When you're trying to make assessments of things like LV systolic function, don't just rely on one image or one measurement. You've got to, as I describe it, see the whole heart. So look at everything together, from the tissue Doppler to subjective assessment to symptoms, blah, blah, blah. Okay? And then the last thing is most important to say is that you've got to integrate these findings into the clinical picture. And if something's not matching up, just try and think, have you made the right conclusions with your echo? Okay, are there any questions about that before we just show you a really quick case, another little pearl and pitfall? Okay, well, I might just swing over onto this other machine. Oh, sorry. Guys, can you hear me? Fantastic. Beauty. Okay, let's go through this case here. Okay, where are we up to? Vijay, do you want to have another go at this one, buddy? I'll just unmute you.
Yeah.
Oh, you're good to go. Fantastic. So, okay, talk to me about LV size and LV function.
This is image taken in pastoral long axis view. The size of the LV looks normal.
Nice.
Because it's on the side wall, it's less than 6 centimeters.
Very nice. So subjective assessment. And let's say you wanted to do it with M mode.
Yeah, I would drop a cursor on mitral wall tip. This is obviously off axis a bit.
Yeah, beautiful. So I've already asked you that before. Sorry to repeat the question. Yeah, very nice. So I think M mode would probably be a bit dodgy trying to assess this. What do you think about the systolic function?
Look, systolic function appears normal, if not hyperdynamic, but I need to look in other views.
Yeah, nice. And one thing that we've got to be a little careful of, and obviously we're always going to try and get down the gun barrel of that ventricle so that we're not off axis. And if we start to see papillary muscles come in, that can be a little bit of an indication that maybe we're off axis a little bit.
Yeah.
And the standard thing is, I'm sure you'd be saying, if this is in the exam, you know, you want to look at other views, but it looks like a normal LV size and normal LV systolic function, right?
Yeah.
Very nice. And what I want to talk about is that if you can see all of these pictures, can you see that the peristernal long axis views look okay?
Yeah.
The short axis views are getting a little trickier.
Yeah.
And then the apical views in this patient, if I carry on trying to go down, it just sort of gets harder and harder and harder to image this patient. And the apical views were nigh on impossible. And what I was hoping to show you is these pictures that were taken, I think it was last week or something, when I was reporting echoes a few days ago or something. The sonographer called Jenny, who does imaging for us, one of her great talents is doing subcostal views, I think. And what I was hoping to show you is an example of how she uses the subcostal imaging for something that's much more than just our standard our standard subcostal view is this as we know it, right? Where we've got our, we're imaging through our liver. We have the marker pointing towards the patient's left with slightly maybe anti-clockwise rotation, and we're up underneath that xiphoid looking up at the heart. And we have our right ventricle, right atrium, left atrium. But Jenny often sort of goes off axis or off piste, and she will get views like this. So she'll come and slide the probe round a little more laterally if she can. I think it helps if a patient's got a bit of hepatomegaly, maybe like this one. And she's able to get, sort of off axis 4 chamber views almost here. And what this is useful for is that she went ahead and tried to use this to estimate tricuspid regurg, which I thought was quite innovative. This patient didn't have a lot of regurg, but it's just an example that you can go off axis to try and get views from your subcostal view. She had a go at doing her tissue Doppler imaging so that we could have a look here with our, if I wanted to measure the S prime, you know, we can see here, so it's the marker that's coming up on the tissue Doppler, and typically S primes of greater than 10 indicate normal RV systolic function. Again, this is probably off axis, but if you haven't got any other options, this is a way of trying to image a difficult to image, trying to estimate systolic function in a difficult to image patient, in this case on the right ventricle. And then I guess what's probably easier to try is some of the other imaging, that particularly these kind of views. So if you just rotate the probe 90 degrees, you can get your short axis view from your subcostal views. And here's our LV at the mitral valve level with our RV on top. And here's imaging through the liver, trying to get a short axis view. So particularly looking for regional wall and things like that, it's really useful. And although she didn't actually record the picture, I'll just show you this one where you can see her starting to fan up. And if I pause it at the right part, I'm just going to scroll it back a little bit. So this in the short axis, scrolling up from the mitral level. And here you've got the aortic valve in the middle, the RV wrapped around it. There's the tricuspid valve at the top. And here's the pulmonary valve and pulmonary artery, excuse me. And this is a really nice view. You can actually get quite nice Doppler angles down there through the RVOT to measure things like your, seeing if you've got the flying W sign or signs of pulmonary hypertension. So I guess I mention this because it's, sometimes we can have obviously difficult to image patients. And if you do have difficult to image patients, we can use, if the 2D's hard, we can still do subjective assessment. We'll try and use all views possible. We can use M mode if we can, if we've got half decent pictures. We can use our tissue Doppler, and for the LV, looking for systolic prime or S prime motion greater than 7.5, suggesting normal ejection fraction. We can look at our stroke volume. We can look at our mitral regurg, DP, DT, or we can use our subcostal imaging. So don't forget to use this, and you can still try and get lots of different angles from your subcostal imaging. I think it's probably all the time we've got for today. Were there any questions or any comments about LV size and function? Or from you, Lee, if you wanted to write any on Dan? All right, well, if there are no questions, I might say we'll call it quits for the presentation. We'll go on and I'll stop the filming and we'll go on and talk about some of the written questions, and please, you're more than welcome to hang around if you'd like to for those. So maybe I'll say thank you very much, and I'll just press stop on the computer, okay? Thank you.